Good morning, everyone. My name is Nadine Haddad. I'm an epidemiologist working at the Epidemiological Surveillance Program at the Ministry of Public Health in Lebanon, and I'm also a MediPIET fellow. I'll be presenting my work about the risk factors and the mumps vaccine effectiveness during the 2014-2015 mumps outbreak in Lebanon. Let's just begin by a quick refreshment about mumps disease. Mumps is a viral infection primarily affecting the salivary glands, and the virus is transmitted by direct contact or by airborne droplets from infected people. The symptoms develop 2 to 3 weeks after infection, and they include headache, muscle pain, fever, and swelling of one or both of the parotid glands. The disease is generally mild in children, but it's more severe in adults, and it can lead to complications in adults such as meningitis and orchitis. There's no specific treatment for mumps, and prevention is by immunization. Mumps vaccine is administered in combination with measles and rubella vaccine, referred to as MMR vaccine, and its vaccine effectiveness is estimated in the literature review for one dose at 78%, ranging from 49% to 92%. As for 2 doses, it's estimated at 88%, ranging from 66 to 95%. Now, the worldwide occurrence of mumps outbreaks, even in highly vaccinated communities, raises the following question. Is it a question of vaccine effectiveness, or is it a question of waning immunity over time? In Lebanon, mumps is a mandatory notifiable disease, and it should be immediately notified to the Epidemiological Surveillance Program, ESUMO, referred to as ESUMO, at the Ministry of Public Health, and it has several levels of case definitions. As for the MMR vaccine, since 1996, the first dose was administered at 12 months of age, and the second dose at 4 to 5 years old. Now, for the second dose, this one has shifted to 18 months old, starting 2014. If we look at the estimated mumps coverage in Lebanon, according to the WHO, UNICEF, and the administrative estimates of the second dose of MMR in Lebanon, from 2004 till the year 2014, we can see that before the year 2008, there were some sort of fluctuation of the coverage. But if you look at the official or the administrative coverage, if we look at the year 2008, it was estimated administratively at 30%, but after the year 2008, the administrative coverage was almost 90% and dropped up to 69% in 2014. So before 2014, for the past 3 to 4 years, we had good coverage, according to the estimates. If you look at the mumps occurrence in Lebanon, we can see that according to the epidemic curve for the past 5 years, a mumps outbreak started in 2014 and continued in 2015. And in fact, the national mumps incidence per 100,000 population increased from 0.6 in 2010 to 12.7 in 2014 and up to 33 in 2015 as an annualized rate. If we look specifically at the age-specific incidence rates in Lebanon for the last 2 years, 2014 and the annualized rate in 2015, we can see that the most affected age group is 5 to 9 years old, followed by 10 to 19 years old for both years. And these 2 age groups should be at least targeted with at least 1 dose of MMR vaccine. If we look specifically at the cases vaccination status among the Lebanese cases aging from 1 to 19 years old, as reported in the classical reporting form and as filled by the healthcare workers, we can see that for both years, around 1/3 of the cases were reported as vaccinated, and another 1/3 reported as not vaccinated, and the remaining were unspecified. Now, in order to understand better this outbreak, we have conducted our study in order to identify the risk factors for the mumps occurrence in 2014-2015. And the second objective is to estimate the mumps vaccine effectiveness among the Lebanese population during this outbreak in order to provide guidance for interventions and immunization policies. Our study design relied on a matched case control using phone-structured interviews. The cases were Lebanese mumps cases between 1.5 and 19 years old, reported to ESUMO between 2014, week 46, and 2015, week 11, the time that the study has initiated. As for the controls, they were recruited by systematic random sampling from the National Phone Book, and they were matched by age and by locality to cases. They were eligible to be enrolled in the study if they were Lebanese, without mumps history, and as they report, and with no contact with mumps cases during the past 25 days. We have calculated our sample size using the OpenEpi online tool for the 5% level of significance, 80% power, and ratio of cases to controls, 1:1. The minimal sample size needed was 94 cases and 94 controls. We have collected our information using a structured questionnaire, and we have collected the following variables: demographic characteristics, whether they self-report being vaccinated against mumps or no, whether they have vaccination card available with them, and we have also asked to read to us the documented mumps vaccination dates. Our data was entered using EpiData version 3. We have defined the vaccination status according to the presence of documentation. So they were classified as having a documented vaccination status if cases and controls have their vaccination card available with them. They were classified as vaccinated against mumps if the mumps vaccination dates are documented, and they were classified as not vaccinated against mumps if the subjects report themselves that they are not being vaccinated at all, or if they don't have a vaccination card, or if they have a vaccination card but with missing vaccination mumps dates on it. We have calculated the odds ratios and the 95% confidence intervals using the conditional logistic regression using Stata version 13, and the vaccine effectiveness for 1 and 2 doses were calculated using the following formula: 1 minus odds ratio times 100. Now for the results, 94 cases and 94 controls were enrolled between March 2nd and May 22nd, 2015, with a mean age of 11 years plus or minus 4. Around 60% were males and 90% were school students. The household crowding index was significantly higher among cases than among controls, 1.79 for cases and 1.22 for controls. Now, by looking at the mother's educational level, we can see that cases, mothers were significantly having a lower educational level, primary level or less, as compared to controls mother, 55% compared to 12% among controls. And if you look specifically at the vaccination status, the way we have defined it, we can see that 36% among cases were classified as vaccinated or having the documentation. Sorry, this one, figure 6, is documentation. So 36% among cases have their vaccination cards with them, compared to 71% among controls. And by looking at the definition of vaccination status, 16% of the cases, they were defined as vaccinated, compared to 48% among controls. Now, by looking at the number of mumps doses among those who were classified as vaccinated in each study group, for 1 dose, 9% of the cases have received 1 dose, compared to 13% among controls, and this was not significant. And for 2 doses, 7% only among cases have received 2 doses, compared to 35% among controls. And all of the differences were significant between cases and controls at 0.05 level, except for the 1 dose among cases and controls. Now, for the vaccine effectiveness by number of doses, the vaccine effectiveness for 1 dose was calculated at 58%, but the 95% confidence level ranged from minus 19% to 85%, and this has several possibilities. One of them probably is the low sample size or low frequency for the cases that were considered vaccinated. And the vaccine effectiveness for 2 doses was calculated at 87%, and the confidence interval ranging from 63% to 95%. Now, all of the factors that were significant, all of the variables that were significant at 0.2 level, they were entered in the model, and the remaining variables were significant in the final model. Not being vaccinated with an odds ratio of 8, so cases were 8 times more likely not being vaccinated compared to controls. Another significant variable was the mother's low educational level with an odds ratio of 4, and another variable was the crowding index with an odds ratio of 3. Our major findings are the following. A suboptimal MMR coverage might explain this outbreak, and the identified risk factors were the low economic status, estimated or approached by the crowding index, and the low mother's educational status. And the mumps vaccine effectiveness of 2 doses was estimated at 88% with a confidence interval from 63% to 95%, which is similar to what was found in the literature. So these are the main findings. However, as for any other study, we have several limitations. The main limitation is the statistical power of the study, given that we have a few number of cases that we have classified as vaccinated. And this is another issue because misclassification bias is probable according to how we define the vaccination status among cases and controls. Another misclassification bias is the possibility of having asymptomatic controls who have reported not having any mumps history. And another limitation is the question about the accuracy of documented vaccination status, mainly by healthcare workers, because probably they have written the MMR vaccine and the label where they should have written the MMR vaccine. And this is something that we cannot ascertain even if we are looking ourselves at the vaccination card. So our recommendations would be to put more preventive efforts in order to achieve high MMR coverage through enhancing the routine immunization system and to implement a valid vaccination documentation system. And for future studies, it's recommended to ascertain the controls status by serological testing to rule out whether they had mumps history or no, to rule out the asymptomatic infection, and to estimate the vaccine effectiveness according to the vaccine strain used. And thank you for your attention.
Thank you, Nadine. Question, please. Yes.
Thank you. That was a really excellent presentation. Well done.
Thank you.
Just a technical question. I noticed in your choice of controls, you actually chose controls on the basis that they had not been exposed to a mumps case in the.
Yes.
Now, controls are it's often said controls should actually represent the situation in the general population. So I just wonder about this issue about no contact with a mumps case during the past 25 days. What the rationale for that and what discussion you'd had over that?
Yes, that was specifically during the past 25 days in order to rule out whether they were incubating the virus and not being classified as cases later on if we were continuing the study. I know that we should not be selecting the controls based on that, but specifically 25 days only in order to rule out whether they will be considered cases later on.
Okay, I mean, it's an interesting discussion that we had in the MediPIET program over some time, is that actually controls, there's no reason why control cannot be a case if they're being selected on the basis that they represent the true level of exposure and disease in the population. But for very low prevalence or relatively low prevalence conditions, it doesn't matter which it is. But it's an interesting point to reflect on, I think.
Do you think that we should have selected them regardless whether they had similar cases or no?
I think probably strictly, if you follow, say, what Rothman says about the choices of controls and case control studies, you probably wouldn't have used that model.
Okay. There is another question in the back.
Yes, please.
Thank you. Thank you, Nadine, for your excellent presentation. I'd like to ask about if Ministry of Health carried out subtyping of viruses to see if it is still matching with the vaccine subtypes or not.
Okay. You will see, okay, up till now, all of the cases that are reported are suspected or probable, according to the different case definitions that we have. Now, fortunately, with my colleague next, we didn't have till now genotyping or typing for the virus, but my colleague has initiated that, and you will see that in the next presentation. As for matching this with the vaccine used, we are still conducting this research to see, because we are not sure when did the shift in the vaccine strain changed, or according to the regulations, or according to public or private sector. So we are still working on that.
Yes, please.
Really very good presentation. Just one question. Among cases, all of them had a phone at home?
Yes, they were, yes. In the database, we had cases that didn't have a phone number. So we only recruited those who have a phone number. And then, just a second. And then among the, okay, I cannot see the slide anymore. Anyways, cases were only having a phone number. So in the database, those who don't have a phone number, they were excluded because we didn't have any other way to approach them. And among cases, we had also several people with wrong contact, so wrong phone number given. So we tried as much as possible to recall the hospital to see whether they would give us another phone number, but it was limited only to those who have a phone number. I cannot see it anymore.
Thank you for your presentation, and thank you for the passion when you are presenting.
Thank you.
This gives us a positive attitude. My question is about when you are asking about contact, telephone them. Did you see the card for vaccination, or did you ask them only for being vaccinated or not? For the contact?
For the
For the
contact?
selected contact, yes, yes.
For the controls, you mean?
For controls, yes, yes.
For both of them, we assess the vaccination status and the vaccination dates in the same way. And this was done using only the phone call interviews. So we didn't see any vaccination card.
For the cases only, you didn't see it?
No, for both of them, we assessed the same way. So we have contacted them using the phone, the phone calls, and we have asked them whether they have the vaccination card, and we have specifically asked them to look at it and
Okay.
to give it and
To
to
give you the
read it to
results.
us.
Okay, okay. One other comment that if you think that this mumps is due to low vaccination coverage, do you think that you will have measles outbreak, for example?
Yes, we already had measles outbreak in 2013,
Yes, yes.
and it continued in 2014. And also we have conducted a case control study about the vaccine effectiveness of measles back then, and we have reached the same result,
Okay,
that it's low coverage.
thank you.
Any other questions?
Thank you.
Nadine.